Good evening and welcome to the special Heart Foundation webinar offering an update on absolute cardiovascular risk assessment. We all know that cardiovascular disease rates have declined over the past 20 or 30 years, but cardiovascular disease still remains one of the most important contributors to morbidity and mortality in Australia at the moment. We're very pleased that you've joined us tonight, and if you have any questions, please feel free to ask us through the webinar, and there's a message box in the bottom right-hand corner of your screen. And although we are very keen to hear from you, unfortunately, we won't be able to answer all your questions because of time restrictions. Now, let's just get started, and I'll introduce the panel. Firstly, myself. My name is Nigel Stocks. I'm Professor and Head of General Practice at the University of Adelaide, and I'm also a GP in the Adelaide Hills. On my far right is Professor Mark Nelson from Tasmania, who is also a GP and academic, and he is a chief investigator on two cardiovascular-related trials called ASPRE and STAR-E. Sitting next to him is Professor Kim Greaves, who is a cardiologist from the Sunshine Coast, and he's had a career-long interest in cardiovascular disease, as you might expect, but he's also been a researcher for a number of years as well. And then sitting next to me is Dr. Carissa Bonner, who is a behavioural scientist who investigates how to improve medical decision-making and communication in primary care, and with a particular interest in cardiovascular disease. So, well, welcome to all of you, and through the evening they'll each be answering questions from you, and also telling us about cardiovascular disease risk assessment. Now, it's very important that we start with a history about absolute cardiovascular risk assessment, and Mark Nelson has been associated with the development of guidelines in Australia for the past 10 years, and he's going to talk about the progress of absolute cardiovascular risk assessment in that period. So, please, Mark.
Thank you, Nigel. Well, the process started in 2009, but was actually predated by a New Zealand approach, where they decided to move away from guidelines which had traditionally been prepared from isolated risk factors such as blood pressure and cholesterol. And we thought that was a good idea, so groups formed the National Vascular Disease Prevention Alliance. They included the Heart Foundation, the Stroke Foundation, Kidney Health Australia and Diabetes Australia. And in 2009, there was the first guideline was produced, which was assessment of absolute risk, where we introduced the Australian Risk Calculator, which was a risk algorithm developed from the Framingham score, and it was recalibrated for an Australian population. That was followed in 2012 by the management guidelines 3 years later, and these are shortly about to be updated, but the current guidelines still are the 2012. During the period of time between 2012 2017, the Heart Foundation was, amongst others, such as the College of GPs and the National Prescribing Service, were out promoting these guidelines and the fact that we needed to move away from individual risk factor management towards a holistic approach of absolute risk score and treatment based on absolute risk score rather than the artificial constructs of hypertension and dyslipidemia. One bulwark that we did have was that the Pharmaceutical Benefit Scheme criteria, which I'm sure everyone will remember, was quite complicated. There was about 10 or 11 different criteria, and it didn't seem to be evidence-based, and we made the argument that we needed to move away from that and to an absolute risk approach, which means if you were at risk of having heart disease, so either had manifest heart disease or at high risk, you could get statins and you didn't have to meet those criteria. So in 2017, those criteria were changed, and now anybody who needs it can get hold of it. And of course, the more recent development has been the development of this new heart assessment item number for the Health Insurance Commission, which became active on the 1st of April of this year.
Very good. Well, that's a very good summary, Mark, and thank you very much for that. But of course, we have had this cardiovascular risk assessment tool available for some time. Most countries overseas have developed their own cardiovascular risk assessment tools in the UK, in the United States and other countries. But are people using them? And I was going to ask whether Kim in particular, whether people are using these calculators and what that means for under and over treatment of our patients.
Thank you, Nigel. So, first of all, I'd like to talk about, if you can bring the next slide up, thank you, about draw your attention to the bar chart on the left. And this was work done by Emily Banks in 2016, where they looked at 9,500 patients from the 2011 Australian Health Measures Survey, where they were able to calculate patients' absolute cardiovascular disease risk scores. And this was because they had information on their biometrics and also the medications that they were taking. And from this, they were able to estimate the proportions and absolute numbers on guideline recommended therapy. And then taking that information, they were then able to extrapolate this to estimate what was going on in the Australian population. Now, if you look at the graph itself, on the x-axis, you'll see there is the 5-year primary CVD risk. So this is basically patients who are not known to have prior cardiovascular disease. And if you look on the right-hand side there, greater than 15% is the high-risk group. And only 24% of patients were actually on the dual guideline-recommended therapy of a statin and an antihypertensive agent. And so that meant that 76% of high cardiovascular disease risk patients who were no prior CVD known were missing out on blood pressure and lipid-lowering therapy. So what does that mean? So they then extrapolated this, and we know that there are 7.3 million Australians between the age of 45 to 74 years, and that's about 1.45 million, according to their data, at high risk of cardiovascular disease. And of those, about 615,000 patients are walking around at high risk who are not currently receiving the guideline-recommended therapy, which is clearly a lot of patients. Now, you might say, well, that's just the one study. However, if you look on the right, data from the NPS Medicine-wide database, which has 3.5 million patients data within it, representing 650 general practices. 750,000 patients were at high risk, and of these, they were able to calculate that 43% of these patients were not on a statin. So really, this tells us that it's a less than an ideal number of patients or proportion of patients are at high risk are not receiving the correct therapy. So I think this establishes that really that there is a problem, that patients are perhaps not receiving the therapy as they should be. So the next question is, well, why not? Why isn't this happening? What is the problem? And I guess the first thing to look at are the assessment rates. And there's quite a bit of data out there. We decided to conduct a study on general practitioners, 111 general practitioners, where we actually asked what the absolute cardiovascular disease risk assessment rates were. So we asked GPs, how often did you undertake a risk assessment in eligible patients? And we categorized them into high assessors, so those high, moderate and low assessors. And high assessors are essentially those GPs who carry out assessments in more than 80% of their eligible patients. And low assessors, we said, carried it out in less than 60% of their patients. And then using this, because we had a kind of gradation of data, we were able to look at the association between their assessment rates and various factors related to the general practitioner demographics and other organizational characteristics, if you like. And what we found is that about 17% of GPs said that they assessed 100% of all eligible patients, whereas 10% said they didn't assess at all or very rarely. And then we had an in-between section. So high assessors, about half of GPs said they did it in more than 80% of eligible patients, and about a quarter were what we called low assessors, assessing in less than 60% of patients. Again, this is one study, so what else is out there? Well, the Heart Foundation themselves last year carried out their own survey, and they had very similar data to ours. In 260 patients they assessed, or GPs they assessed nationally, 40% of GPs said they assessed it in everybody that came their way, 50% said they did it sometimes, and 10%, similar to ours, rarely or never. So that tells us perhaps that our assessment rates are perhaps not ideal. And so the next question really to be asked is, well, what are the predictors? What predicts whether these assessment rates actually occur? So because we had a spectrum of assessments, we were able to carry out regression analysis and look at some of these predictors. And we had some interesting findings, so I'll just take you through them briefly. Those GPs who felt that they had sufficient time in their consultation were much more likely, or significantly more likely to undertake risk assessments. Because we asked general practitioners and quizzed them on their knowledge of the cardiovascular disease risk score, those who had better knowledge were significantly more likely to carry out an assessment, suggesting that knowledge is a factor. And perhaps surprisingly, those general practitioners who were over the age of 45 tended to be lower assessors. When we looked at the patient factors, those GPs who felt that their patients would be motivated to make lifestyle changes or behavioural changes, they were much more likely to assess. And those GPs who felt that the patient actually was able to understand or grasp the concept of absolute cardiovascular disease risk were more likely to be assessed. So it was quite an interesting set of data, and yeah, I'm interested to see what you think.
Yeah, thank you very much, Kim. It's amazing that we have this discrepancy between what people actually report that they're doing and the objective data from GP data that suggests that maybe it's not occurring so well. Is there any reason for that, perhaps?
I think one of the main reasons is that in previous studies, they tend to, the questions, certainly from the data that I've read, that when they do a survey, it's really, do you use cardiovascular risk assessments, yes or no? And rarely in the studies that I've read, did they actually say, well, how often do you do it? What is the proportion? So rather than having a binary outcome, it's much more useful to say, well, how often do you actually do it? And perhaps that's why we're getting
perhaps people are a little bit optimistic about how often they do it.
Yeah, so you could argue that the result, because this was self-reported, perhaps that the data we're getting is actually perhaps more optimistic than is actually what's happening.
And the other aspect of your research is that you actually found that people, perhaps who lower socioeconomic groups, who may be at higher risk of cardiovascular disease, are less likely to have their risk assessment done because they may not understand the charts or things like that.
Yes, so I haven't actually carried out that research, but certainly from what I've read, patients that have a lesser understanding of cardiovascular disease risk perhaps are less likely to adopt behavioural change.
Lower health literacy,
yes,
perhaps.
Yes.
Yeah. Mark, do you have any comments about Kim's work?
Yeah, I mean, there's an old adage, it doesn't matter what occupation you're in, you tend to overestimate what you're doing. And so it is a really good idea, rather than guess what you're doing, is doing a self-audit and looking at your own records and seeing, am I doing a good job? Because I think you'll find that you'll overestimate how well you're doing. And I think that's just human nature. It's nothing to do with general practitioners. I think everybody behaves that way.
And I know we'll come to some behavioural aspects of cardiovascular risk assessment, but Carissa, do you have any comments on what Kim has just been talking about?
Yeah, I think it's interesting that his research found GPs were sort of assessing whether their patients would be able to understand the result before deciding whether to do a risk assessment. So we'll come to a bit more detail on that later, but there are different ways that you can explain risk in a way that people with low health literacy can actually understand.
And even the percentages, because percentages are sometimes a difficult concept to try and convey to somebody who's not mathematically minded.
Yeah, and even, well, for all humans, understanding probabilities is actually very hard. Even if you look at statisticians, we all have certain biases that make it difficult for us to understand probabilities. So there's different ways that you can communicate absolute risk to patients in a way that they're more likely to understand. So in our research, we've looked at some sort of GP perspectives on when they find it useful or not so useful to do the absolute risk assessments. And very similar to your findings, it's often when they feel like they could use it to motivate the patient, but also when they feel like the patient will actually understand. So very similar findings to you.
So it sounds like there's no single cure for this issue. There are multiple factors at play that we need to address.
Yeah. Could I ask the panel if there are any comparative studies with other countries, New Zealand, Canada, UK, Netherlands, countries that have very similar healthcare systems to us? Is there some evidence that we're doing poorly with respect to them or better maybe?
I think the best evidence had come from New Zealand, and what's happened there is that Rod Jackson, one of the people who came up with the concept of running on absolute risk, has now got 400,000 people linked through primary care, and the process has become automated. So if you're in those practices, not only the absolute risk score is done automatically, but there's a two-way communication of data between the practices and Rod so that he can improve the risk algorithms so they're accurate. Because I know one concern about general practitioners is what's in the risk algorithm and what's missing, because classically obesity, family history, so things that we know that are important risk factors but don't appear in the risk algorithms. And by him keeping it up to date and contemporary, he can actually keep those things redialed and have an accurate risk estimation contemporary.
10% of the population in New Zealand, that's pretty good.
Yeah.
Really, that's very good. We do have a question from a member of the audience, and Kate asks, how do we measure success with absolute CVD risk? Should we have a national target? Good one.
What do you mean? The thing about absolute risk is that the way we want it to be utilised is a decision aid for you to decide who you treat, and rather than just treating on individual risk factors, is that it's a threshold for treatment to say this is a person who's likely to have covert coronary artery or cerebrovascular disease, who's likely to manifest in the next 5 years, and you give them effective preventive drug agents, blood pressure and cholesterol lowering agents. And once you do that, is that then you treat to targets according to the individual risk factors. But the important thing is to just make the decision to treat. And I'll give some illustration later how using an absolute risk score rather than relying on the traditional blood pressure and lipids in isolation is a superior way to preventing those first heart attacks. And remember, the prevention paradox is that most people who have a heart attack, it's their first one, it's not their second one. Even though the people who have already had a heart attack are at higher risk, if we want to prevent heart attacks or strokes on a population level, we need to prevent those first ones.
Yeah. Well, I guess in the audience there are people who are going to ask the question of, well, it's all very well to do an absolute cardiovascular risk assessment. What does that actually mean in terms of patient outcomes? Because that's, after all, what we're really trying to do is improve patient outcomes, whether it's prevention of cardiovascular disease or stroke, or at least improving risk factors in some way. So I'm going to turn over to Mark again to give us a little bit of background about that. Thanks, Mark.
Okay, so I'm going to illustrate this, why it's important to do absolute risk scores rather than rely on traditional risk factors in isolation. I mean, there's two aspects to it, is that we know that if you manage people on absolute risk rather than individual risk factors, you're probably going to prevent twice as many major adverse cardiovascular events. And as an illustration of this, I wanted to look at just one of my patients who I saw. This was a chap who came to see me after having a inferior myocardial infarction. So you'll be pleased to know I hadn't seen him prior to his event, but he came to see me after the event. And I mean, there's a lot of things we need to do when somebody comes and sees us about having an acute event, and we deal with his acute management. But after the event he'd been in, is that I do what's called a critical event audit. I look at this person and say, is there anything we could have done to prevent this event before it occurred. And in this case, you can see there on the slide these are his actual measures, and they were his pre-event measures because he'd been seen at my practice prior to the event. So if somebody had done an absolute risk score, they would have found out he had an 18% absolute risk, and he should have been intervened with blood pressure and cholesterol lowering. But you can see there, if you looked at him from the perspective of individual risk factors, there's nothing there with the exception that he was a smoker that may trigger you to use drug therapies. You might think of nicotine replacement or centrally acting agents for smoking cessation. But with a traditional approach of dyslipidemia or hypercholesterolemia and hypertension, you wouldn't be giving him drugs. And yet he went on and had his infarct, and he would have had that significantly reduced if he'd been initiated on that prior. And almost within days, I had another fella came in, same circumstances, except he'd had a stroke, and he was 70-something. His absolute risk was 23%. So you will see them in your practice. And the Heart Foundation did a lot of good education around this, and they promoted it as, we all know the one person who dropped dead who surprised you, because he didn't have any risk factors. But of course, the problem was he was a male aged over 50. So already he's got a lot of risk factors. And we need to assess on their modifiable risk factors according to their overall risk. So in my practice, I make decisions based on absolute risk.
So, Mark, in that case, what would you have put your money towards? Was it stopping smoking, or was it lowering the other risk factors?
Well, the one criticism about people who say, well, with a 15% trigger and you say, put them on drugs, is that you ignore the risk factors. Well, of course you don't. Is the risk factors, the modifiable risk factors that are behaviourally based have the highest priority. Your number one determinant of risk that is modifiable is your smoking status. So, no, you deal with you have an intervention regarding his smoking cessation, but also he's the fellow you start on the drugs, and you need to do both. So it's significant behavioural intervention, but these people need drugs. The flip side I mentioned about the low-risk people who tend to be treated, you'll have a 42-year-old female with mildly elevated statins or a blood pressure of 142, and on medication it's 138. I mean, what have you really done for us? So the other thing is that on that flip side, you're preventing somebody from being given a diagnosis, being medicalised for the next 50 years, because that's how long they'll survive, because there's such a low risk. And you mentioned, you may not have mentioned, but I run a blood pressure clinic which takes referrals. And about a third of my patients, I'm stopping medication because they're low-risk individuals with no underlying secondary cause. And in those cases, you can look into them, for example, the 42-year-old female with mildly elevated blood pressure, and have a chat to her about her alcohol intake. Because by dealing with that behavioural aspect that's driving her blood pressure, you'll have effects that are lifelong, not only on cardiovascular disease, but things like liver disease and cancer.
Although there are, going back to your case again, in terms of smoking, there are additional benefits of giving up smoking other than cardiovascular risk in terms of cancer risk and other things. But yeah, thank you for that insight. I'm going to go to the other end of the spectrum in terms of managing cardiovascular disease in the hospitals, and Kim is a cardiologist. And so he's recently looked at a risk profile of patients who are presenting with ACS. What did you find, Kim?
That was very interesting. So we've experienced exactly what you brought up there. So I thought, well, let's look at over 13 months, we looked at the patients presenting with acute coronary syndromes to our hospital, and we were able to assess their cardiovascular risk as they came into the door and estimate what their absolute risk was at that point in time before they received treatment to lower blood pressure and cholesterol and so on. And so over 13 months, we had 688 acute coronary syndromes, of which 60% it was their first time heart attack, if you like. And of these, according to our data, about 35%, so 141 out of those 402, were high risk, so greater than 15%. And of these, how many of these were then on treatment? And actually 70% were not on adequate therapy. So half of them were on no treatment and the other half were on single therapy. And so maybe you could argue that perhaps if these patients were on treatment prior to this, then you may have been able to mitigate some of these events.
Do you know why they weren't on treatment? Is it because they didn't want to have treatment, or was it because they hadn't been offered or hadn't been assessed?
I don't know. We didn't assess that. You can only really hypothesize, I suppose, as to why, and that goes back to the Emily Banks data, and we've already talked about that. Perhaps they weren't getting assessments, or the patients were refusing treatment, or whatever. There's a number of factors I think that are involved as to why this isn't occurring, but it just highlights that although we can talk about what's going on in the community at the moment, we actually are seeing the thin end of the wedge in the hospital of large proportions of patients who are high risk presenting with heart attacks who are not on correct therapy.
And the evidence suggests that 85% of all Australians present at least once a year to Australian general practice or a GP. The average is 7 or 8 times a year. And I know that obviously varies by age, but you would expect people in the at-risk groups to be at least coming to general practice at least once a year. So there is an opportunity then perhaps to assess risk.
Absolutely.
Very good. All right. I have to check my tablet to find out whether anybody else has asked any questions, and it's currently blank. So if you have a burning question, please send it in to us and we'll try to answer it for you. I'm going to pass over to Carissa, who can further elaborate, I think, on communicating risk to patients, because we touched on it before, and it's actually quite difficult in some respects, but actually quite easy in others. And so can you just talk to us about your experience, or talk to the audience?
Yeah, sure. So I've been leading a study called the Healthy Heart Study for 7 years, which has been looking into why GPs do and don't use these guidelines, and particularly trying to work out ways that we can make it easier for GPs to use absolute risk assessments. So one of the things that consistently comes up is this difficulty in communicating risk. So we know that 60% of Australians have low health literacy, which means they have trouble understanding and acting on information about their health. So that's not surprising that GPs are finding it hard to convey this concept. So under the old guidelines, where we had cholesterol guidelines and blood pressure guidelines, and there were a lot of abstract numbers that you sort of had to get your head across, that was even harder. Absolute risk assessment actually gives us an opportunity to communicate risk in a simpler way. So we know from cognitive psychology that people find it easier to understand frequencies of events than abstract probabilities or abstract numbers like you'd find in a pathology report. So with absolute risk, what you can do, if we maybe pull up the next slide, is we can convey that percentage in the form of a frequency. So there's been a lot of research in the risk communication field showing that even people who have very low education or low health literacy in other ways can understand risk if it's presented in the right way to them. So instead of saying 18%, we can say 18 people like you out of 100 would expect to have a heart attack or stroke in the next 5 years. And even better if you can show it as a diagram like this, that actually means something to people. So if we want people to either change their lifestyle or consider taking medication, which is lifelong medication, and we know adherence for those sort of interventions is very low over the long term, then we really need to get across this idea of why are we actually wanting them to take this intervention. And when you put it in these sort of terms, it starts to become a bit more meaningful to patients. So on this next slide, you can see that for the case of Mr. X, where his risk was 18 out of 100, if we had perhaps explained to him that if he stopped smoking, that risk would have been reduced to 10 instead of 18, perhaps that would have been somewhat motivating for him to take some action on his smoking. Alternatively, if we wanted to focus on the medication, as Mark was pointing out, we can also put that in frequency terms. So we could say, if there was 100 people like you taking a statin, we would actually prevent 4 of those heart attacks or strokes. So presenting the information in terms of frequency is one way that you can convey this information in a simpler way.
Very good. Thanks, Carissa. It's interesting, guys, because I sometimes use the analogy of a football team to some people about a football team at least in South Australia, an AFL team is about 24, 25 people. And so if you have a chance of having a number needed to treat of 1 in 25, you can actually put it to your patient that to benefit the football team, all of you have to take a statin or lower your blood pressure so that one of you in your football team will not actually have a heart attack or stroke in the next 5 years. And I guess you wouldn't necessarily use that for women, although with the new AFLW league, you might want to be using those sorts of analogies. But if you put it into those contexts of what is important to an individual patient, you may have more chance of conveying in some way what their risk is and how other people could actually benefit from them taking medication.
It's interesting, Nigel, because I use another sporting analogy. I always use the first Tuesday in November because they run the Melbourne Cup. And another way of putting your risk, if you've got a 15% absolute risk, is you're about a 7-to-1 shot. If you're in the Melbourne Cup, I would back you. And people do understand that 7-to-1, that's a good priced horse, so perhaps I should do something about my behaviour.
Mm-hmm. Can I ask the clinicians in the audience whether you use risk factor, these sorts of charts in communicating with patients, or whether you have any thoughts about their use?
Certainly, when I do my clinic, I don't have the benefit of this nice slide of 100 people with these dots. And I've seen this once before, and the Mayo Clinic uses something similar. And I think it's excellent. It certainly is hard. You can see it's hard to convey these figures without the use of diagrams and so on. So I tend to explain it verbally, but I will certainly be using these diagrams now that they're on, I think, on the Heart Foundation website.
Oh, so they're quite downloadable. So that's an easy thing to do.
Yeah, I use because the absolute risk, the Australian risk calculator is now in the major clinical software. You can actually do the score and print it out. So that's what I do. I print it out, make sure they've got a copy of it. And I would also then physically write down all the things that they need to do, and as well as I would start immediate prescribing. Now, we do know that not every prescription is filled, and our clinical lives are littered with stories about patients who take it out, drop it in the bin and find another doctor. So I'm sure I'm not perfect when it comes to risk communication, but that's the way I do it. I utilise the software in the clinical software.
And for those patients who are IT literate, there are various websites which actually give you graphical presentations of these types of risk assessments. And the Heart Foundation has one. There are ones from overseas. It depends on the sophistication of your patient and whether you feel that they can actually utilise that information in a positive way. I guess maybe fortunately or unfortunately, those patients are the very ones who probably will be more adherent to medication and to setting some long-term goals for themselves. We don't want to lose sight of, in talking about medication or ceasing smoking, about other aspects of lifestyle changes, such as increasing exercise, which a number of patients do find difficult. But my advice to most people is just to do a little bit of extra exercise each day by walking an extra few minutes. Allgate is in the Adelaide Hills, and some of my patients I've recommended to walk uphill to the bus rather than going downhill to the bus, and therefore to get some real exercise where they actually get slightly out of breath or slightly sweaty when doing so. I must admit, on one occasion, after such advice, one of my patients did get exertional angina, and he did end up having a stent, but he did come back to me because he felt that we'd identified a problem before it became more severe. So sometimes following your advice can actually be a good thing. I do have several more questions now, so I better get on to these. So Himali from Tasmania asks, patient with diabetes, age 65, CVD risk assessment, high risk, blood pressure 128 on 84. Do we need to start her on blood pressure medications on top of lipid-lowering medications, irrespective of persistently normal blood pressure?
Yeah, so we need to get away from the concept of normal blood pressure, because that assumes that you've got this dichotomous measure. It's a continuous variable, Above 140, you're hypertensive, but below that, you're normotensive. If she's 128, she's a high risk. She's 65. Is that what we do know is that diabetes is a big driver of risk in women that it is in men. You basically lose your advantage of being female by developing type 2 diabetes. So the ideal blood pressure is 115. One thing that optimal treatment studies have shown for blood pressure is that there doesn't seem to be any lack of benefit no matter where you start from. So there's no doubt that she would benefit from having her blood pressure lowered from 128 to 120 or 118. And if she's got diabetes, if you choose the correct agent, you'll have renal protection as well. So you can think of the person holistically as a cardiometabolic disease. So I think it's a lay down misère. We need to get away from this idea of hypertension and normotension. We just need to say, what is the optimal treatment for this patient? And the good thing about it, if she's got a blood pressure of 128, it's going to be relatively easy to get her down those few extra millimetres of mercury.
Maybe she'd be one of those few patients that only require one antihypertensive medication rather than the average of 2 to actually control their blood pressure.
Yeah.
Kim?
Yes, I agree entirely with that. It should be dual therapy.
Very good. I've got another question here. Dorothy asks, where does coronary calcium scoring fit compared to absolute risk estimation? I think Kim, the cardiologist, can answer that from his viewpoint.
So calcium scoring, yes, there are guidelines out there now from Australia and also European and American guidelines. And essentially, they recommend that calcium scoring should not be carried out in patients who are high cardiovascular disease risk and not in patients who are low risk. But you can consider using calcium scoring in the intermediate risk group to see whether you wish to go on with treatment at that point or withhold. So if the patient's got a calcium score of 0 and they have an intermediate risk score, then you may consider not treating them. However, if they have a calcium score of 100 or 200, then certainly you might wish to consider treating them with dual therapy. And that's where it is at the moment. There are all sorts of controversies about calcium scoring. There's no clear treatment for calcium that's elevated. When you bear in mind now there's very good evidence that statin therapy actually increases or lipid-lowering therapy, including statins, increase your calcium score over time. So you can't now do you can't treat someone on the basis of your calcium score and then repeat the calcium score on say every 2 or 3 years, because their calcium score will go up purely by virtue of the statin that you're using. So that clouds the issue. Then, of course, there's also the issue about downstream testing as a result of high calcium scores. You may end up sending them for functional testing. So there's a lot of cost issues, a lot of extra investigations that you end up doing that may be unnecessary. Perhaps if you just started off with the Framingham risk equation or the ACVD risk score in the first place.
Yeah, I'd agree. There's a very good correlation between the risk algorithms and these more expensive, invasive, and in some cases irradiating investigations. So, low risk or high risk, it doesn't make sense to do a second test. And as Kim has said, it may be useful when you're considering somebody who's in that intermediate threshold. Do I treat or don't I treat? Just as we should consider other things like family history or morbid obesity or other extraneous risk factors like a high-risk population. If they come from South Asia or Eastern Europe, for example, you might have a lower threshold for treating than you would in the general Western European or Caucasian
Aboriginal Torres Strait
population.
Islanders in the Australian context.
Yeah, exactly.
Yes,
yeah. Well, Aboriginal and Torres Strait Islanders are a very special group. I mean, the risk algorithms have never been able to reliably even have a correction factor. And that's probably because Australian Aboriginals are not a distinct group. There's a lot of heterogeneity. You've got from the Tiwi Islanders to people down in Hobart, very different population groups. They're at much higher risk, but it's not standardised. And we probably should be a lot more aggressive in management of Aboriginal and Torres Strait Islander peoples than we are in the non-Indigenous populations.
Thank you, Anna. I think I will squeeze in just one more question. Caroline asks, once a patient is taking medication for hypertension and hyperlipidemia, is it useful to assess their absolute cardiovascular risk using treatment-controlled blood pressure and cholesterol measurements?
The answer is no, is that it's a threshold for treatment. The reason why I'd say no, because your number one driver of risk is your age. So your absolute risk will continue to rise because you're getting older. And so is that it becomes a management of those risk factors. So you treat the goals where you can and accept it where you can't. But redoing it after you've decided to do treatment, for example, or after they've had an event doesn't make any sense because their risk, which is a calculation of an untreated group with no disease, once they've got a covert disease or they're on medication, it will underestimate risk anyhow. Yeah. Because it's not designed to answer that question.
So you don't use it for educational purposes to say you've decreased your risk?
You can use it to motivate, but my frustrating thing is that as doctors, we often educate our patients. We say, look, you're at high risk, you need to do this, and we don't do what we should need to do, which is we need to prescribe in these high-risk individuals. And so we're letting our patient down by trying to motivate them. We should motivate them, as you said, to walk, to eat better, to moderate alcohol, to stop smoking, but we should give them the medications in the high-risk groups.
And again, I emphasise that although we talk a lot about medications, because that is certainly the best way of reducing some of these risk factors, because we all struggle as GPs to get people motivated to lose weight, to change their diets, to stop smoking without potentially some help, and also to exercise more. So that's really our main, tools for reducing absolute cardiovascular risk. And so we just have to manage as best we can. All right, it's now 7:42, and I'm getting looks from the Heart Foundation that I must get on to talk about the new Medicare item number, which was released on April the 1st. quite.
Is there anything in that, Nigel?
Anyway, that item number is 699. If you haven't already come across it, there is another item number 177, but that's for a minority of healthcare professionals, GPs, who don't have vocational registration, as I understand it. And this item, Heart Health Check, was introduced because there was a sense that we are not, in Australian general practice, assessing absolute cardiovascular risk as often as we might. And the government felt that there was enough evidence to decide to try and increase that, so that we can actually improve primary prevention of cardiovascular disease, of heart disease and stroke. And there are very specific criteria about this item number that must be fulfilled to be able to claim the number. But as I understand it, and I think as the panel understands, that these things, it can be a shared consultation between a practice nurse, for instance, and a GP. So if we go through some of the relevant information, is that you have to take a patient history, which you probably can quickly do, and obviously identify cardiovascular disease risk factors, including diabetes status, alcohol intake, smoking, cholesterol status, if not performed in the last 12 months, and a blood glucose. Obviously, you want to find out if somebody has diabetes. You have to conduct a physical examination, which would normally be just a blood pressure, unless you had some targeted sense of wanting to listen for heart murmurs or other things. So that will be very, very patient-specific, but would obviously include maybe taking a weight and estimating their BMI and probably a waist circumference. And then it's initiating interventions and referrals to address the identified risk factors, and then implementing a management plan and providing the patient with preventive healthcare advice and information, including those modifiable lifestyle risk factors. Now, this may sound like quite a lot for the amount of remuneration that is provided, but nonetheless, I think that even within a busy practice, it will be feasible to be able to undertake that, and especially if you have a practice nurse to be able to initiate some of the data collection, some of the organisation, and leaving and even looking at the cardiovascular risk, maybe providing some initial input into that, which the GP can then actually reinforce the message and provide the needed assessment and treatment as required. Clearly, down the track, you will need to follow up on that health assessment and provide further backup, further checking of blood pressure, response to medication, adverse events. Perhaps the panel would like to talk about some aspects of this that are of interest.
I would include a formal cardiovascular systems examination, because you might find covert disease. For example, you might hear carotid artery disease or something like that. I think you can do it opportunistically, and because if you do a blood pressure there and then, as you know, you need repeated measurements over more than one occasion, at least a week apart, so you need a collection of them. But if they're attending your practice, often that data may pre-exist. So there may be the opportunity for the infrequent attender to do an opportunistic one, assessment, but critically to do an absolute risk score. But I think you're right. I think the logical thing to do is to do this systematically and treat it like a Clayton's chronic disease management plan. You don't have overt disease. You're looking for covert disease by identifying through being high absolute risk. But doing it so that if data's missing, if you haven't screened them for diabetes or you don't know what their lipid levels are, is that they can be ordered. And then when you do see them, you've got all the material there to make an accurate absolute risk score estimation.
So systematic search of the practice records, identify people who perhaps
you've
in
got
the
your age
range. You've got your age range.
You've got your age range. You can search by exclusionary criteria such as established coronary heart disease or stroke. And there are also groups that are deemed at high risk purely through clinical basis. For example, people aged over 60 who have type 2 diabetes are considered a clinically manifest high risk. So you might want to identify them as a group who you're saying is, am I treating their risk factors? Because as we know, type 2 diabetes is a cardiometabolic disease, and one of the advantages of absolute risk scores is that it forces you to take attention of the cardiovascular risk factors where you might be concentrating on blood sugars and the complications of microvascular disease rather than macro.
Kim?
So, I'm not a general practitioner, obviously, but I have a few ideas. So when PenCS, I think 28 out of 31 PHNs have the system, and a large proportion of general practices do. When we've examined it in our region, there are a number of patients you can identify who are high cardiovascular disease risk. So the system calculates it for you, and you are able to see who is on treatment and who isn't from that. And I was surprised to find that there was a large number of patients who apparently were high risk according to the calculator, but were not on treatment. And when I asked general practitioners how was this possible within their practice, the reason they said was because they collect all the data, but they don't necessarily do the risk score. So there is a way in which you can actually identify these patients who are high risk sitting within your practice who may not be on medication, and you can recall them. And so it may sound obvious, but that is something that's possible. And certainly from looking at one or two general practitioners' databases using the PenCS system, you can do this. And this is something that we're going to try out over the next year as part of a research study to see how true the data is and whether it's possible to recall these patients, whether they actually turn up and have it, and whether when we test them again, whether they really are high risk.
And I guess in terms of searching, sometimes we've used medical students who come to our practice for teaching and or registrars to do the searches and to identify the patients. So it doesn't have to be a task for the GP or the practice manager, or necessarily inviting somebody from the PHN or somebody else. It's a case of what is appropriate in your own practice. Chris, do you have anything else to add to what we've been talking?
So there's also the RACGP will also offer professional development points for doing certain activities, which this sort of assessment of your own practice can
So a category
fit
1
into.
activity, 40 points, yes.
And there are, on the RACGP website, there's a number of audit and feedback exercises that you can participate in to get those professional development points. So maybe combining that with a recall system like Kim suggested, using the MBS item numbers could be a good way to sort of kill two birds with one stone.
Very good. So, I mean, we've got this new item number. We don't know how many have been utilised to date. I mean, we're almost a month in, so it'll be very interesting over the coming months and years, actually, to see how things develop, because this is an item number that can be claimed each year, unlike the 45 to 49-year-old health check, which was only a one-off in that age group. This can be claimed every year on a recurrent basis. And I know there has been criticism of the item number because basically you could charge a level C, but really what this item number allows you to do is to be able to do it in 20 minutes if you so wish. I mean, I'm not saying that as general advice because every patient will be an individual and may require more or less time, but you obviously have to do 20 minutes at least. And it is an opportunity. We did some research some years ago looking at health checks conducted in the community and in general practice. And the Cochrane Review suggests that health checks are of no value for improving health outcomes. But when we divided the place where the health check was undertaken into those that were done in the community and those that were done in general practice, surprise, surprise, those that were undertaken in general practice actually could demonstrate a benefit in terms of morbidity, not mortality because they weren't designed for that sort of outcome, but certainly in improving short-term risk factors, that they were a benefit in general practice. And although we could not claim to know the reason why, we hypothesised that it was because GPs have a responsibility to act on those results. If you have a health check done in the community, say it be in a pharmacy or somewhere else as part of a study, nobody has the obligation to be able to follow through with that information and do something about it. But a general practitioner does. And that's where these health checks can actually come into fore. It not only identifies whether somebody is at risk, but it also then places an onus on the GP or the practice to do something about it. And I think that's important to recognise. And what I suppose the government and the Heart Foundation, and I guess everybody would like to see, is that people who are identified at high risk actually do get some form of treatment. Even if you only lower the risk, maybe not to the optimal level, but at least reduce it, you are getting some benefit. And that is very, very useful. And as we've discussed already, some of the lifestyle modifications that are recommended, whether it's improving diet or increasing exercise or stopping smoking, have spin-off effects for other chronic diseases in general practice. So I think there are a lot of things to be potentially identified through the heart health check that actually will improve Australian health.
Okay. Nigel, I'd just like to make another point too. If people are concerned about workforce issues, if you're in a rural practice where you just don't have the person power to do these, the best evidence suggests if you do have a low-risk individual, is that likely the minimum period of time that they're likely to require to be reclassified as somebody who needs therapy considered is 10 years. So once you've done it, if you make an initial assessment and you find that typical 42-year-old female with a less than 1% risk, is that that's somebody you can put in a recall to do it again in 10 years. That's not somebody who needs it every year for the next 10 years, even though you're entitled to claim for it. But if you want to be efficient and find the high-risk individuals, which is really what this process should be about, leave the low risk alone. You can check their blood pressure every year, but you don't have to formally do another thing because they're only another year older. Yeah. Remember, your big driver of risk is your age.
Yes.
It's the ones where they're near the thresholds of treatment, the intermediate group, the group who are 9%, who you might consider at 10% doing it, who you may want to do it yearly. So you don't have to do it annually for everybody. The one thing is that once you do that first assessment, you can then stack them, you can prioritise who you need to see annually according to that and who you need to intervene.
I've got a question actually for the general practitioners. So I spoke to a general practitioner colleague who worked at the PHN, and I said, what do you think, what is the response rate if you sent out you did a recall for your high-risk patients? And he said he tried this and he got a very, very low response rate, something like 1%. Do you have a feel for, if you did a letter out and call, do you think you could get the high-risk patients back for treatment? If you looked through your system and you found out that there were 20 or 50 patients who were high risk who were not on treatment, you thought, I must call them back. What do you think your response rates would be?
Are you talking about a general review asking everyone to come in, or the high-risk individuals?
Just the high risks.
Well, you see, I think it's the old inverse care law, isn't it? Is that the high-risk individuals are probably least likely to attend.
So
Because
these people have been within the 2 years, so I've looked at the system and I've seen others. They've been within the past 2 years. There's nothing else wrong with them necessarily. I mean, some of them were diabetic, not on treatment. We identified some of those over the age of 60. But
Nigel, I suppose the best information would come out of the chronic disease management plans. And it's like everything, is that the people who you see the more often are the ones who turn up to get it done. That's almost a pattern of behaviour.
So it could be difficult actually getting your hands on.
Yeah, no, I could understand that, because it's just human behaviour is that the people who are frequent attenders are the ones who are more likely to take up on evidence-based
How do we get
reviews.
them back?
I think the major thing from my perspective, we've done some research about patient reminders in the waiting room. Now, that does require a system where you can actually interrogate the database and print off an information sheet for people who require it, information about a particular problem that they may not recognise. So in cardiovascular disease, if you had, for instance, this algorithm running in the background, you would be able to print off these sheets for patients to consider, because when somebody comes to visit me, we want to address their problem that they're presenting with. But by giving them some information in a timely manner when they can do something about it, we've used it for immunisations, for instance. So pneumococcal immunisation, we can give them a sheet saying that they're due for a pneumococcal immunisation, and although they've come for some other reason, they don't have to have it then, but they can come back. Or they can have it there and then because, why not? You know, they're primed. And so I think in the future, our systems in general practice need to improve to be able to accommodate these sorts of things, so that when somebody does come in, we might be able to prioritise some of the things, preventive health activities, that they're due for.
I think also, just from a behaviour change perspective, it really depends what the recall letter said. So for it to actually be motivating for somebody to come back in, it needs to make sense to them. So if it's very much focused on their cholesterol results or their blood pressure results, and those numbers don't really make sense to the person, then there's no reason why they're going to come back. So again, I think the communication is actually a key issue.
So you think your diagram of the 100 people with the...
Yeah, or it doesn't even necessarily have to be as complicated as that, although the Heart Foundation has funded the development of a website that can produce those, they're called icon arrays. But even just putting it in words that you are at high risk of having something like a heart attack or stroke, rather than focusing on the abstract numbers, may be helpful.
Yeah. I talked about printed reminders for the waiting room, but these days a lot of practices are using reminders for appointments to make sure that people do turn up. Text messaging.
Yeah.
And that text messaging is increasingly being you can deliver health messages in that text messaging. And so there are unique ways that we may be able to improve people's awareness of the fact that they may be at risk and do require something a little bit more than just a blood pressure check. And I think that we will, you know, as researchers, we want to explore this, but as clinicians, we just need to be aware that we need to identify those people at high risk and actually do something about it, because it does make a difference. Now we've come to 7:59 Sydney time, and I just need to be able to say a few more things about if you want any more information or access to the resources, visit the Heart Health webpage on the Heart Foundation. Oh, it's up there now. That's very good. I want to thank the panellists and the audience for their attendance. And I wish everybody a happy Heart Week, because that's coming up now. And so good night to everybody, and I hope your practice day goes well tomorrow, because Wednesday is my clinic day, so I've got to get back there for a clinic, as I'm sure Mark does as well. So good night to everybody, and again, thank you very much for attending.